Hello guys, am I clearly audible and visible to you? Let me know in the chat box. And welcome to all of you on the radiology session number 2, which is the part 2 of radiology important topics which we are covering for FMGE 12 January exam. Just let me know in the chat box.
Unit test.
Clearly audible and visible. So we'll start the session. Right, I can see on my second screen. Am I clearly visible? I don't know about the audio. I think audio is also okay. Who guys are watching live, please let me know in the chat box. Audio video is perfect. We'll start the session then. Waiting for your comments. Good evening, good evening. Audio is perfect. Let me know. Yeah, I can understand. You can. I'm visible clearly, but let me know about the audio only. Let me know about the audio. Audio is perfect. Yes. Good evening, good evening. Good to go, right? Okay. Let's start. Let's start the radiology session. And in this session, I will going to cover up all the important images also, because in the radiology, most commonly they are asking you the questions from the your images based, right? Image based questions are more over there, right? And also some theoretical questions also, which is repeatedly coming in the your FMG exam. So we'll be going to cover up those important MCQs also, right? So let's start the session. And starting with the session again with some important MCQs. So I will be going to show you the MCQ on your screen, and you have to reply in the chat box your answers, right? And then we'll be going to discuss about the all the options which is given in the MCQ. Okay, perfect. Audio, video, both are perfect. Good to go. Let's start the session. Let's start the session. So, starting the session, before the starting session, just I'm introducing myself. I'm your Dr. Vaibhav Ahuja. I'm going to cover up your radiology session for today. And if you have any doubts related to this session or any other session which we already put it on the already live saved on the your Meduhub channel, so you guys can contact me on my Instagram. My Instagram handle is dr.vaibhavahuja, right? Also, if you are not using the Instagram, you can contact me on my Telegram also. My Telegram username is dr.vaibhavahuja. Without the dot is the in the Telegram, and with the dot if you're using on Instagram, that will be my channel. So if you have any doubts, you can free feel to ask me and contact me. And if you have any doubts related to the sessions which is held on the Meduhub channel, so you can contact us a Meduhub team also. So Meduhub team is also on the Instagram, so you can follow them on Instagram also, right? Meduhub FMGE, right? Let's start the session. Starting the session with the first important MCQ, which is in front of your screen. Just try to reply me in the chat box answer. Okay, I'm waiting for your answers, guys, in the chat box. Please try to reply me in the chat box. Okay, so starting with the first MCQ, that a 45-year-old male presented with the abdominal diffused abdominal pain. So the patient is having the complaint of pain, right? And the shallow breathing. The patient is having the shallow breathing will be there. On the palpitation, there is a rigidity. There is a rigidity will be feel on the abdomen palpation, and there is a gardening all over the abdomen presented. Was done a erect abdomen X-ray. So we are doing the erect abdomen X-ray, right? On the erect abdomen, this is shows what will be shown in the picture, your diagnosis. So they are clearly want to ask you about the diagnosis of this patient. They will clearly want to ask you about the diagnosis of this patient by seeing this X-ray. So I want to ask you, what will be your answer? What will be your answer? So the options are given on your screen. You can see here the 45-year-old male is there, diffuse abdominal pain. So we did the abdominal erect X-ray is done, right? So in the X-ray, what we are going to find here, can you see something related to this? That options are mentioned there, that shallow breathing is also mentioned. So something it's the examiner want to diverting you related to the some lung pathology, right? But as you can see on the your X-ray, the lungs are totally clear, right? The lungs are totally clear. So there is a no issue was seen in on the lungs, right? Also, the options are given like the acute gastritis is given, pneumothorax is given, gas under the diaphragm is given, and hilar lymphadenopathy is the option is given. So now how to rule out this, that what is on this X-ray. So as you already know, we talked about in the part 1 about the X-ray. So you already know about it, that X-ray, the air on the X-rays come on the black color, and other tissues will be on the seen and the white color. The dense is the white color, right? Like the bone is on the densities, so this will be going to see on a white color. So you can see this is the heart of the patient, and these are the lungs over the patient, but lungs are totally seen clear. There is a no lung pathology is going to seen in this condition. But now when I'm coming to the your abdominal area, where's the so the X-ray is done for the erect abdomen, X-ray is done. So when I'm seeing on the abdominal area, so what I'm going to find here, I'm going to find up here that this is the diaphragm. I'm drawing the diaphragm. Can you see this is the diaphragm? And I can find up here some blackness is here on the left side and on the right side. So as you already know, there will be the, if there will be the abdomen, in the abdominal area there is a blackness, it means some air is deposited in there. But what about the your abdominal area, is the possibilities are there, the normally that air comes to in the your abdominal cavity, not possible is there, right? So what is happening there, it seems clearly that the gas under the diaphragm is seen, and also the option is suggesting us which is your diffuse abdominal pain, right? So when the question keywords are giving you the diffuse abdominal pain, so there will be the gas under the, so what is the answer of this? Yes, so answer of this MCQ is the your gas under the diaphragm, right? Now your question is there, then sir, why they are going to confuse us with the shallow breathing? Why they are giving us the shallow breathing? Why there will be the shallow breathing, guys? As you already know, if the gas will be under the diaphragm, so it will be not, the gas will be going pushing the diaphragm above, right? And the above the diaphragm we are having the lungs, so now the lungs cannot do the expandation, right? So in the breathing, when we are doing the inspiration, so our lungs is doing the expandation, right? And in the expiration they will be going to recoil, right? So now there will be the not possible to expand more over there, so that's why the patient is having the shallowing of breathing, right? So don't be confused that it will be the pneumothorax or what. I will going to show you the pneumothorax X-ray will be also I will going to show in this session. So just clear about it that this is not the your pneumothorax. This is the disease related to your abdominal, and in the abdominal area, as we checked there will be what is the seen to us. We saw there is a gas under the diaphragm. Gas under the diaphragm. Right? Very good. Very good, guys who are replying the C. You all are correct, guys. You all are correct. All right. Let's move forward. Let's move forward. For the moving forward for the next word, that the answer is clear, gas under the diaphragm. And if I'm talking about it, so as the also we talked about the explanation, as you already know, the acute abdominal pain was gas under the diaphragm, which we saw there. And also if the option is not given as the gas under the diaphragm, they can give you the option which is also known as the pneumoperitoneum. So in the peritoneal cavity, if the air will be there, that is known as your pneumoperitoneum. That is known as your pneumoperitoneum. And of course, please remember this is your medical emergency, right? The air gas under the diaphragm, the air under the diaphragm is your medical emergency, because it required the urgent evaluation of the management. That how this is possible in the pneumoperitoneum. Please remember there is a free air in the peritoneal cavity, right? And we have to diagnose it how the air comes to that. Maybe there is the some intestinal perforation is there, right? So we have to diagnose this, and this is your medical emergency. This is your medical emergency. And please remember, as we diagnose this patient with the your erect X-ray, so we can do the erect X-ray also. And if on the X-ray the air is very minimal, so if not visible on that, we can do the NCCT abdominal also, right? We can do the NCCT abdomen also, right? So we are done with the chest X-ray and the abdominal X-ray, because the patient is has a shallow breathing also, so maybe there can be the possibilities of the your pneumothorax also, right? So that's why we did the fully, right? Abdominal, erect abdominal, and erect chest. Your chest X-ray also should be done in this condition. If on the X-ray it is not visible, so we can do, right? If patient is stable also, please remember, if patient is stable, right, diffuse abdominal pain is there. If patient is stable, no issue. If unstable, please remember, if the patient is unstable, please remember about it, this is a medical emergency. So if patient is unstable, we have to do the, first of all we have to do the X-ray. Otherwise, how we can evaluate that patient is having the pneumoperitoneum or not? If the patient is having the pneumoperitoneum and if the patient is unstable, so we have to do the laparoscopically. If the perforation is there, so we have to do the urgent laparoscopy, yeah, or laparotomy should be done, right? We have to do, right, urgent. Okay, we cannot wait for it. We cannot wait for it. Okay, we have to done for this. Like if perforation is there, we have to close the perforation, doctor, right? Okay, now let's move forward. Moving forward for the next thing, that your next MCQ on your screen, guys. Please check it out. This is given. Again, the 45-year male, which is having the epigastric pain. What the patient is having now, again, the epigastric pain. And with the increasing after the meal, guys, please remember the patient is having the pain also, epigastric pain, but it is increasing what? Increasing after the meal. And the patient is having the hyperglycemia. So these all are the keywords, guys. Please remember, patient is having the hyperglycemia and have the steatoria. Was done the investigation below. All of the following are true about the given. So what is this about this investigation? They want to ask about it, that which investigation is done here. So what you think, guys? What is this? The epigastric pain the patient is having. Also hyperglycemia is there, and the patient is having the steatoria is there. Guys, very good clinical case is given to you, and of course they mentioned you all the important, they given you the also the important key features are already given to there, right? Peptic ulcer perforation complication will be the bleeding will be there, doctor. If the peptic ulcer will be going to burst, right? If the peptic ulcer will be going to perforate, right? So there will be the scene, the bleeding will be more. Okay, bleeding will be seen, right? Because peptic ulcer in the inner side of the abdominal and maybe in the duodenum, right? And the part of duodenum, right? The starting part of duodenum, D1, right? So there will be the, if busting of that, so there will be the more bleeding will be going to see. Okay, and the yes, tube is visible, right? Tube is visible. We are seeing the tube is we are seeing. What will be the diagnosis, guys, in this case? Okay, I agree with you. You all are replying. The option is your ERCP, sir. Option D is there. Can anyone of you can diagnose this? What is this patient a diagnosis? Then we done with the ERCP. In which case we are doing this ERCP. Can anyone of you can reply me in the chat box that what is your diagnosis of this patient? So you are going with the ERCP and we done with the ERCP. Any ideas? Any ideas? Also, the key features are given to you. Also, yes, the pneumoperitoneum was the last question. Yes, exactly. Pneumoperitoneum was the last question. Patient diagnosis. Then we done with the ERCP. Tell me about. I'm talking about this one. I'm talking about this one. The patient is having the hyperglycemia, having the steatoria, and the patient is having the epigastric pain. Increase after the meal only. They mentioned you this that it is increasing after the meal. So what should be your diagnosis in this case? Reply me in the chat box. I'm waiting for your answers, doctors. Right. So let's talk about it. So as you can see, the clearly mentioned as in the comment also doctor is replying. So we can see this pipe will be visible in this, right? So there are the options given. The MRCP is there, MIBG is there, HIDA scan is there, and ERCP is there. So in the ERCP, we are putting a tube inside the abdomen, and this is the your ERCP is the your diagnosis in this condition. Okay, so this is the ERCP. I'm waiting for again my question which is remain there. I'm waiting for your answers, guys, that what is your diagnosis, and let's talk about this. So what is the mean of your ERCP is there, guys? In the ERCP, this is your full form of ERCP is your endoscopic retrograde pancreatography. Okay, so we are doing the endoscopically retrogradely we are doing the colio, it means your gallbladder, and colio angio, right? Pancreatography, right? So colio angio, so and colio angio, and we are doing the pancreas also. So both will be going to visible on the your ERCP scan, and that's why the doctor is replied there. That's a we are visibling is there. The pipe is seen there, right? So this is the endoscopic pipe we are which are putting inside it, right? So this is the your yes, doctor. It is correct. It is correct. You are already absolutely correct that this is your your case of ERCP. Of also gastric ulcer will be not the possible, guys. For the gastric ulcer we are not doing the ERCP. For the gastric ulcer we are doing the just simple endoscopy we are doing. Okay. So dumping syndrome, yes, it can be possible, and biliary tree obstruction, of course, it can be also the possibilities are there, right? Yes, possibilities are there, right? So that's why we are doing the ERCP in these conditions, okay? And this endoscopic procedure for the identifying, maybe there is a stone which is making the blockage on the your yes on the your pathway of the biliary ducts, and if the stone is present there, or maybe the tumors will be there. Can be the tumor will be also can be possible on the pancreatic tumors can be there, and also the narrowing of your biliary tree, yes, or biliary ducts or the pancreatic ducts, guys. So for the seeing this pancreas and your gallbladders, yes, for seeing this we are doing the performing the ERCP. Yes, we are doing the ERCP. Yes, chronic pancreatitis also can be possible, right? Also possible, right? Because there are the already they mention as the hyperglycemia, right? So we think about this little bit. We are thinking about it. The pancreas is going to release your glucagon and insulin, right? So there is a disbalance of this only. Then why only the possibilities of the your hyperglycemia, right? Am I right? Okay, from the medical terminology, if I'm going for the medicine subject point of view, so as the word are mentioned there, hyperglycemia, and also the steatorrhea is also mentioned there. So it means something seen there, that the steatorrhea will be, there is a fat in the your stool, right? Fatty stool will be there. So the fat digestion will be done by your biliary, yes, from your bile salts, yes, from your bile juice. So that is also not coming. It means something nearby the narrowing of your biliary tree or the biliary your pancreatic ducts, right? So closing of that. So of course it can be possible in the chronic pancreatitis also, right? It can be possible in the pancreatitis also. So for the ruling out this all the things, for the ruling out this for the ruling out and making the perfect diagnosis of it, so that's why we are doing the ERCP in this condition. So that's why we are doing, guys, ERCP in this condition. Is it clear to you about your doctors? Is it clear? Right? Is it clear? Okay, let's move forward. Let's move forward. Now we are moving forward for the next MCQ. Very good, guys. You are answering very well. You are answering very well, right? So please remember about it. For the making the diagnosis, we are doing this. Okay. For making the diagnosis, we are doing this. And as you can see, there is the pipe is clearly visible to you. So this is your what? This is your ERCP. We are putting the endoscopically, right? Which is the retrograde, and this is done in the cases of your pancreas or the pancreatic or the your yes. Very good. Let's move forward for the next MCQ. Moving forward for the next MCQs, on it's on clearly seen to your on your screens, and a female child was found to having a dribbling. A female child was found for the dribbling and incontinence was, so there is a done investigation which is shown image below. So they didn't mention the which is the your investigation is done. They just given you the history and the key feature, what is the clinical feature is there. There's a dribbling and the incontinence of the urine will be shown to you. What is the name of this technique? They want to ask you about the technique which is used here. So images is clearly visible to you, guys. So I hope you know about this investigation. Please try to reply me in the chat box. So options are given to you, your MCU, VCU, pelvic X-rays clearly, and IVP. What you guys are thinking? Of course, it's a kind of X-rays taken by here, right? X-rays there I can understand to you. But which kind of X-ray? Not only the normal pelvic X-ray. Is it not the pelvic X-ray? Right? It is not the normal pelvic X-ray, right? And they clearly mentioned you about the dribbling and incontinence was done. So there is a something we are going for the urinary things. Okay. Okay. So Dr. One is replying that this is the IVP and we are seeing the Stranghorn calculi. Okay. 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 What about others? What about others, guys? I'm waiting for others. I'm waiting for others. Is this the Stranghorn or is it the drooping lily? Is it the Stranghorn sign calculi? Can you Stranghorn calculi you are writing, doctor? I agree with you. But is it the Stranghorn or the drooping lily sign? Can you differentiate between this both of it, which is seen both are seen on the IVP, right? Intravenous pyelogram. MCU with the inverter, not possible, doctor. Option A is not the possible. This is not the MCU, right? This is not the MCU. So let's start talk about this. So on this X-ray, what is the clearly visible to you? Can you see about this ureter and this kidney, right? This kidney, and you can clearly see this ureter, right? This is the ureter, which is clearly visible. So there is some dye is used on the X-ray, yes, and you can see over there this also. This ureter is also visible to you, okay, and this dye will be going to deposit it now in the bladder, and then we can do the more X-ray also, right? So as it is from your kidney area, yes, from the kidney area. So what is the mean? This is the not from the MCU. Okay, so what is this, guy? This is not the pelvic X-ray is the possible. So what is this? Yes, is it clearly seen to you that this is your intravenous pyelogram? This is the intravenous pyelogram is this. Now I'm asking about it. What is your diagnosis for the seeing this patient? What is your diagnosis of the seeing this patient? Uh, okay, so doctor is here confused again and saying yes, it's a drooping lily, and the diagnosis is doctor is saying the duplexy of the ureter. Okay, 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 okay. Let's talk about it. Let's talk about it, doctors. So this is the correct answer. That this is your intravenous pyelogram, which is done here. And if I'm talking about it, this is the intravenous pyelogram. So we are putting a dye inside the veins and we are taking a x-ray of it. So this is the imaging test which is look to the kidneys and ureter. We are doing this in the kidney and the ureters, okay, and the ureters are the narrow tubes that carrying the urine to the kidneys from the bladder, right? I agree with you, but this is all about it. But I'm again asking you, what is this a diagnosis? Again the doctor is saying sir, duplexy of the your ureter is seen to you, but I don't think so. I'm zooming in little bit about the image, so I think this is clearly visible to you. Can you see here? Now can you see here, doctor? Is the drooping lily? Is the drooping lily, as you mentioned me there, is the drooping lily or the Stangon calculi? I think now I zoomed in the image, so I think it's clearly visible to you now, perfectly visible to you. For the making it the diagnosis, can you see that this is not the duplexy is not the scene here, right? There is the no two ureters. Okay, for the duplexy will be going to seen clearly. There will be the two ureters will be going to separately going to start it from there, right? And then they will be going to join. But there is a no two ureters. Okay, there is a no duplexy of the ureters, doctor. And yes, this is what this is your Sanghorn calculus will be presented there. Okay, so we are doing this IVP for the your kidney and ureters related. Okay, so for the kidney disease and ureter disease, we are doing the intravenous pyelogram. For the later investigation, we can do the for this we can do the for the seeing the kidney and ureters, we are doing this. Also, we can use the USG also, but on the USG we cannot be will be the visibility will be not there. But if any obstruction will be there, that will be clearly visible to us, right? So this is about your intravenous pyelogram. Okay, so please remember about the IVP that this is the imaging test which is for looking the kidney and the ureters. We are visible, the ureters will be going to clearly visible to you. Is it okay? Is it okay, guys? Should we move forward? Should we move forward? Very good. Let's move forward for the next MCQ, and the next MCQ is in front of your screen. And the clearly they are asking you which of the following the correct explain the image given image. So the image is given to here, and they are asking you about this image. This is the single bubble sign, gas in the abdomen, and the multiple air fluid levels are seen here, or maybe the none of the above. So what will be your answers? Please reply me in the chat box. Please reply me in the chat box. Please reply me in the chat box. What will be the your answers? So the options are clearly given to you, and of course, this is also your erect X-ray. Yes, erect abdomen X-ray is given to you in this condition. So we are talking about little bit about the GIT diseases, and also respiratory X-rays will be going to cover up. No issues, doctor. Option A, can you please explain? Yeah, I will going to explain your single bubble sign. Of course, doctor, I will cover up your single bubble sign. Just wait for it. Just wait for it. Just first of all, cover up about the, just let me know what is your answer. What is your answer? Just let me know. We'll be going to cover up your, this will be going to cover up. Single bubble sign will going to cover up. Try to reply me in the chat box. Very good, doctors. Very good. I can see on the screen you are replying very well. Yes, doctor, I've been going to cover up the single bubble sign. Just first try to reply me in the chat box. Some are saying the option last question. Okay, last question you are asking about it. Just a minute. Sorry for this, doctor. Just a minute. I will going to cover up this. What is the MCU? You are asking about this MCU. This is your micturating. Your yes, doctor. Your option. You are asking about the option A. Last question. This is your micturating cystourethrogram. Write it down here. Micturating rating cystourethrogram. And what is this micturating cystourethrogram, right? Your question is that, sir, what is this micturating cystourethrogram? So what we are doing in this condition, here we are putting a catheter inside the patient's bladder, and we are putting the contrast material in the patient's bladder. So patient's bladder is fully with the contrast material. So we are not doing about the kidneys, we are not doing about the ureters. Please remember this retrogradely, this will be not going, your contrast will be not go to the kidneys. Please remember about it. But image which I shown to you, is it clearly seen to you that this is showing you about the kidneys and the ureters? Please clear about it. So this all will be inside your bladder. And then what we are doing about the after the doing the filling of this, after the filling of this your bladder, we are removing the your catheter, and we are saying to the patient for the urinating this contrast which is filled in the your bladder. And then the radiologist will be going to do the x-ray. Frequent x-rays will be going to done, and there we are seeing the x-ray, the anatomy of your bladder. If there is a something, the shape will be changing of the bladder, or maybe some dye will be going to something deposited or remain inside the bladder. So for seeing this, for the bladder pathologies, we are doing the, for the seeing the bladder pathologies, guys, we are doing the your MCU. So if you want to see, I can show you about the MCU images also. Just give me a minute. I can show you the MCU images also, doctor. I think, is it clear to you now? History MCU1, yes, MCU1 I'm clearing you about this patient history. There will be the not the bladder pathologies will be there. Okay, maybe the bladder cancer is there or bladder stone will be there. I can show you the MCU image also. I'm putting here. Just a minute. Just a minute. So you can see this one image. So can you see this image clearly? Can you see this image clearly, doctor? So this is the contrast material which we filled inside the bladder, and you can see this contrast material is going out through this catheter is put it there. Okay, or maybe the patient can urinate, right? So the when the patient is urinating, for the looking the anatomy of the, we are looking the anatomy of the your bladder, mostly anatomical, or maybe some pathologies will be also there in the structure of your bladder. Okay, so this MCU we are doing the, which is your micturating cystourethrogram. Okay, urethrogram we are doing this. Okay, cysto it means your bladder, and urethra means urethra. Okay, for the urethra and bladder we are doing the MCU, but for the kidneys and the ureter we are doing the IVP, intravenous pyelogram. Is it clear, doctor? Should we move forward? Is it clear now? Okay, perfect. Let's move forward. So we was on the option question. Next question. Just a minute. Okay, so we was on this image. So just try to reply me now in the chat box, guys. What is your answer? Some are replying C and some are replying C. Some are saying A. Okay. So what is your answers? What is your answers? What is your answers for this condition? Okay. Okay, so as you can see there, on this condition, there is no one air bubble in the, there is no one air bubble, and also the single bubble sign. What will be saying? The single bubble sign, only the one bubble of air will be seen in the intestinals. Also in the gas in the abdomen, if we are asking about it, so it will be spread into the only the gastric region and not in the whole abdominal cavity. It will be going to fill. Of course. So what should be the answer in this condition? Of course, this is the your multiple air fluid levels are seen in this condition. So you can see over there what is the blackness is will be going to seen here. This is the air, and what is this whitish color? This is your fluid will be going to seen. Okay. So as you already know, on the X-ray, your fluid will be going to seen in the white color, and your air will be going to seen in the black color. So this is the your multiple fluid air level. So answer should be your C. Option D is not the correct answer. Option A is also not the correct answer in this condition. Okay, guys. So option C is your multiple air levels are the correct answer in this condition. Okay. So this is your multiple air fluid levels which is seen in this condition. And this is being done with the X-ray. Already I told you which is the erect abdomen X-ray we done for this posture, and we found the multiple air fluid levels right in the central abdominal. In the central abdominal with the relative vacuity with the bowel gas digitally, and this is confirming the diagnosis of the intestinal obstruction. Of course, there will be the what obstruction in the distal intestinal obstruction. So due to this, the all the fluid will which will remain in the intestine also, and this air which is accumulated there, that is also remain in the intestine also, right? So this is the scene, the air fluid. Please remember, air and fluid will be on the X-ray will be going to seen differently. Okay, this will be going to seen the differently, not together, not together. Okay, so we can say the multiple gases will be there. Multiple gases will be there with the water, your air and fluid. Okay, so this is about your intestinal obstruction. This is seen in your intestinal obstruction, right? Let's move forward for the next MCQ. Moving forward, the MCQ is in front of your screen, guys. Please try to reply me in the chat box. Please try to reply me answer in the chat box. A patient was brought to the hospital after the RTA. So the patient is having the road traffic accident. So the patient is reached to the hospital after the RTA, and after the RTA, the patient, and please remember they clearly mentioned you that BP of this patient. The patient is having the blood pressure of the patient is the 90/70. Okay, so the patient is having the blood pressure 90/70 mmHg, and X-ray revealed the following conditions. So what is the diagnosis in this condition? So the X-ray is given of this patient, and this patient is having the brought to the hospital after the RTA. So the clinical history is given, RTA is there. Okay, RTA is there. So option is given to you here. The option A is saying the hemothorax, option B is saying the pneumothorax, option C is saying the right perineal effusion, and option D is saying the none of the above. So what you guys are thinking about the answer of this condition? Please try to correlate with the patient. The patient's BP is falling down. Okay, you can understand this thing. Patient's BP is falling down. Okay, and also the patient is having the clinical history of the classical history of RTA. Okay, so patient had the RTA. So now the one thing which I can clear you here also, that we have to see in the condition of the respiratory X-rays. What we have to see in the respiratory X-rays? So in the respiratory X-rays, if we're talking about the, if I'm talking about the respiratory X-rays, so you can see clearly here, which is our CP angle, claustrophrenic angle. This is your CP angle. Okay, which is your claustrophrenic angle. Okay, so now the CP angle on the left side, you can see clearly, this is the left side of the patient, and this is the right side of the patient, right? So we can see here. So what I can see here, I can see here on this side, this is your CP angle is blunt. Yes, which is known as the blunting. Okay, CP angle blunting. Can you see here? This CP angle is not clearly visible. Of course, this CP angle blunting is seen in the right pleural effusion. Is it possible the right pleural effusion? Of course, in the CP angle blunting is seen in the right pleural effusion also. But please remember, if the pleural effusion is there, the patient is not having the history of RTA. So this is not the possible that the patient is having the pleural effusion and he come with up to you with this condition. Okay. Okay. Yes, right-sided, I already agree with you, doctor. It could be effusion because of in the right-sided blunting is seen. But please let me know, in the pleural effusion, should be your blood pressure will be going to decrease, and there should be the your there should be need of your RTA. The option is given to you. Please remember about it. There is a RTA is the clinical given you the RTA is there. Okay, road traffic accident is there. Okay, yes, blunting on the right side is seen. Okay, blunting to hai right side. I am agree with you. But let me know Is it the possibility? Is it the possibility there is the patient is having the this pleural effusion, and then he had the RTA, and of course there will be the not the decreasing of the blood pressure. Okay, the blood pressure which is mentioned here, that is the clinical, that is your keyword. We can say this is the keyword which is given here, and also this is the history which is the after the RTA, so this is also possible. Of course, the some of you are saying, sir, is it possible about the pneumothorax? Please remember, is it possibility the CP angle will be going to blunting in the pneumothorax? Just let me know in the chat box. Who guys are replying B? Just let me know about it. That is why I thought for the effusion there is a no history of RTA. Yes, if there is a no history of the RTA and this X-ray is given to you, that should be your pleural effusion. That's why I'm confirming you, I'm clearing you that what the examiner want to confuse you. You are not reading what happening in the exam. Please understand this thing. What you will be going to do on the 12th January. Maybe this is possible, but after this session, I think you will be not going to do this thing. What you are doing, you are seeing the your just X-ray images, and you saw there is a blunting is there. Okay, yes, no CP blunting will be seen in the pneumothorax. In the pneumothorax, the one area will be totally dark. Okay, so there will be the no air will be going to see there, and that will be totally darkness will be going to see. Okay, I will going to show you the pneumothorax also. Okay, so what you guys are doing on the exam day, on just you saw the X-ray and you answered the right pleural effusion. Okay, you didn't read the MCQ. Okay, you didn't read the MCQ, and this is the this is the trick of the examiner who are making the MCQs, and they are giving you such clinical they are giving you such clinical stages there. Yes, jet blacking of the lung should be seen in the pneumothorax. Okay, and they are giving you just this keywords will be put it on the MCQ, and you are not reading the question. So I request to you, please remember about it. I agree with you. I agree with you that after the seeing the your X-ray, you can make the diagnosis of it. But please, after seeing this image, don't hurry to make the diagnosis of the patient. Please read the clearly. MCQ should be read once, and all the options should be read once. After that only, after reading the MCQ clearly, please make sure you have to find the keywords should be there. As you find it keyword, that RTA is there and BP is given, blood pressure, which is the lowering of the blood pressure, and your mind is seeing that why he is mentioning the blood pressure in the if the pleural effusion is the decreasing the blood pressure. Is it possible? No. And also there is the why they are mentioning the blood pressure, and also they are mentioning you the RTA history also. If the patient is having they can mention for the pleural effusion, they can mention you about the some lung pathologies can be mentioned there. Okay, so please remember, if they are mentioned there are some lung pathologies, so of course this should be your directly answer should be your right pleural effusion. But as they mentioned the RTA, so there are the more chances, guys, there are the moreover the chances of the condition which is known as your hemothorax. And what is the hemothorax, guys? Please reply me in the chat box. What should be mean of the pneumothorax? What you know understanding by the hemothorax? What you are understanding by this word, which is the hemothorax? Okay. So please remember, yes, this is the right sided of your CP angle blunting by the bleed. Okay. As the internal bleeding is there due to the RTA, due to the road traffic accident, as the bleeding is there, so can you understand this thing? As the internal bleeding is there, so that's why your blood pressure is going down. Yes, so your blood pressure is going down. So this both of it. Okay, yes, blood collection is the thoracic cavity in the hemothorax. So can you understand this thing, that the blood pressure will be of course going to down as the hemorrhage? Yes, internal hemorrhage. What will be the clinical sign of internal hemorrhage? Of course that will be going to decreasing your blood pressure. Okay, yes, the internal bleeding will be there. Yes, so in the internal bleeding, what will be going to see? The clinical classification will be seen your decreasing of the your blood pressure. Okay, your blood pressure will be going to decrease. So is it clearly seen to you that this is the your case of hemothorax? This is the case of your hemothorax. I think now you guys will be not doing hurry in on your 12th January exam, right? You have to read the MCQ, you have to find the keywords, and after that seeing the after seeing this your after seeing this your X-ray, don't make the diagnosis in a hurry. Okay, please try to read all the options. Maybe in the exam this examiner is given your hemothorax in the option D, and the first option is given to you right pleural effusion, and what you guys are doing in a hurry, you are marked the A and you moved forward. Okay, don't do such thing, don't do such thing. Yes, the patient will be going to hypovolemic shock. Exactly. So the patient will be going to do the hypovolemia shock. So that hypovolemia will be going to decrease the BP. Yes, blood pressure will be going to decrease first. Okay. So the condition which is seen in this X-ray is it your hemothorax. I hope is it clear to you. So this CP angle which is blunting here, what is here? This is the blood. Okay, and this is your internal bleeding. Okay, this is your internal bleeding, and the case of your hemothorax. Hemothorax. Okay, blood in the thoracic cavity. Blood in the thoracic cavity. Is it clear? Should we move forward? Should we move forward? So I hope you are not doing this such mistakes in your 12th January FMGE exam, right? Now you guys will be not doing such mistakes. Let's move forward. Let's move forward. For moving forward, I already explained you that hemothorax is what? Hemothorax is the blood collection between the parietal and the visceral pleura. Yes, and you already know what is this? This is known as your pleural space. So we have the two pleura. One is the visceral and one is the parietal. So between this we have the pleural space, and in the pleural space we are having the pleural fluid, right? Pleural fluid, which is doing the which is not doing the friction of this. Okay, so this is avoiding the friction. Okay, yes, perfect. So in that pleural space only, if the bleeding is occurred, so your CP angle will be going to blunt there. Okay, if now listen this part, I'm giving you the same question also. If RTA is not given to you, something is mentioned there that patient is having some lung pathology related to some lung tumor. Just come to this again on the same here. Just I'm writing here. If this is not mentioned RTA, and if they are mentioning you are some lung pathology or maybe CA of lung, okay, cancer of the lung, and the blood pressure is also not mentioned. Now tell me, what should be your answers? What should be your answer in this case? If I corrected this MCQ, if I made this MCQ in a different manner, the patient is come to the hospital and the patient is having the lung cancer, and he is having the breathing issues. Okay, we can write it down rather than the BP, having the breathing issues. Breathing issues. Okay, some breathing issues are there in the patient, and this X-ray is clinically X-ray will be given to you. So what should be your answer in this case? Yes, in this case you have to answer the right pleural effusion. Right pleural effusion. Okay, now tell me, I agree with you. If the right patient is having the right pleural effusion, what should be the management in this case? If the patient is come to you with the right pleural effusion, what should be your management? What should be your management in this condition? Let me know. Yes, because the CA lung should be given history of it. Okay, so there will be the clearly, yes, this will be the clearly that patient is having the CA lung. There will be the more chances the patient is having the pleural effusion. Of course, very good, doctor. So we should have to do the pleural tapping, or this is also known, and the pleural tap is known as your thoracocentesis. Very good, doctors. Very good. You perfectly have the knowledge of the radiology also, and for the medicine and surgery also, right? So you know about it. If the patient is coming with the pleural effusion, we have to do the thoracocentesis. Very good. Just one more question related to the anatomy. Can let me know about it. So like this is the two ribs. This is the two ribs where you will be going to enter your needle. This is the rib A. This is the rib B. Just reply me in the chat box, guys. This is the options I given to you. This is the rib A and this is the rib B. Okay. Now let me know. Now let me know where you have to put your needle. Above the A, below the A, above the B, or below the B. This is the A rib and this is the B rib. Now tell me. Now tell me. Very good. Very good. So this was the A and this was the B. So we always go through the upper border of lower rib. So the lower rib is your B. So where I will going to put the needle? I will going to put the needle on the this area. I will going to put the needle on this area, the upper border of lower rib. So lower rib is your B. Yes. So upper border of rib B. Can you let me know why? Why we are putting the on the upper border of B only. Why I'm not going for with the why I'm not giving the lower border of rib A? Why I'm not going with it? Just let me know why. Just let me know why. Can you answer this? Can you answer this? I'm waiting for your answer. We'll move forward then. Because on the lower side of the there is a vascular system. Of course, on the lower side of the rib, there is a not only the vascularity, there are the all the three are transporting. Which all the three? VAN, vein, artery, and the nerve. Please remember about it. So we are not going to on this area. Otherwise, this will be going to disturbance to the vein, artery, and nerve. Yes, yes, not the NV, VAN, okay, vein, artery, and nerve, okay, vein, artery, and nerve. All the three are going through your lower side of your ribs. So that's why we are always going with the upper border of lower rib, and we are entering inside your pleural cavity. Okay, yes, vein, artery, and nerve. Okay, is it clear? So please remember about this pleural tapping also. And nowadays they clearly mentioned this in the emergency condition, or you are doing this. We are going to do the USG guided, yes, sono guided pleural tapping we are doing nowadays. Okay, so there is a no chances to go inside the vein, artery, and nerve. Okay, so nowadays we are doing the USG guided. Okay, so use the USG, right? So we're going to put the USG probe there, and after we are seeing the clearly fluid will be going to seen there, and we are going to enter the needle through the guide of your ultrasound. Okay, so guiding, we are taking the guidance of the ultrasound only. Okay, so USG guided, we are doing the USG guided tapping. Okay, or also the thoracocentesis. Okay, is it clear? Let's move forward. Let's move forward for the moving forward for the next question. Moving forward for the next question, and the next question is in front of your screen. That what is the most common risk factor is disease represented in the given picture. So they given you the picture, and they are asking you about the diagnosis, the first of all the thing. And after the diagnosis, they are asking you not there, they clearly not asking you the diagnosis. They are asking what is the diagnosis you have to make, and then what is the most common risk factor of that particular most common risk factor of the particular disease. So first of all, what I'm going to ask, please don't answer about this. First of all, make the diagnosis and answer me. What is your answer for the making the diagnosis of this condition? Let me know in the chat box. Let me know in the chat box what is your diagnosis in this condition. Let me know in the chat box what is your diagnosis in this condition. Let me know. Let me know. First of all, tell me if this is a which kind of uh, just let me know what kind of what kind of picture is given to you. What is this? What is the given to you in this image? Just let me know. I'm waiting for your answers, guys. Please reply me in the chat box. First of all, yes, this is a CT. CT of thorax. Yes, chest CT. Agree with you. Now tell me what is seen to you in this condition. Some issues with the ventricles. I don't think so. Some ventricles issues are seen to you. Just try to look at. Just try to look at the again. Just try to look at the CT scan again. Can I zoom it? If you want, I can zoom in it. Okay, just wait for it. I think this is the more zoom. Yes, is it now a little bit visible to you? What about now? Just a minute. Tell me, what about now? Just tell me, what about now? Is it clearly visible to you guys? I already zoomed, doctor. I already zoomed it. Just try to check it out. Annie, I hope you clearly seen this. Now also, can you make the diagnosis of it? Can you know about it, that what are the structures are seen in this condition? Just I'm mentioning some things are there. This is your sternum. I'm writing sternum. This is your vertebra. Okay, so this is the sternum. This is the vertebra, and this is passing. Which is passing this here. This structure is your. These are your lungs. Okay, and this is your important structure. I'm marking here. This is your aorta. Now something is seen to you. I think I given you the clear hint. Yes, I clearly given you the hint also. I think now something you can reply and reply me. Yes, very good. You made the now the diagnosis, guys. This is your aortic dissection. Very good. Now tell me, which sign is it? What the sign? Name of this sign, which is seen in the aortic dissection. Just name the sign. Name the sign. I'm waiting for answers, guys. Name the sign. Name the sign. What is the name of this sign? Any one of you? Name the sign. Tennis ball is not the clearly sign. This is known as the crescent sign. Okay. You can say the tennis ball also, it seems, but tennis ball is seen in the different. Okay. Tennis ball is just totally different. I think it's clearly seen to you now. Option is clear to you. Diagnosis you made. Okay. Is it clear? Yes. Tennis ball. Yes, yes, yes. Aortic dissection. Tennis ball sign is seen. Also seen the crescent sign. We can say the crescent also. Okay. Very good. Let's zoom out the picture. Yeah, perfect. Let's move forward now for the understanding this MCQ. Now they are not asking you about the in the MCQ. They are not asking you about the your diagnosis of this condition. What they asked you in this condition, they are asking you about the most common risk factor. So now tell me, what is your most common risk factor of this condition? Can you tell me? Now tell me, options are in front of you. Just let me know what is your answers or in this question. Is the atherosclerosis is the most common cause of aortic dissection? Is the diabetes mellitus is the most common cause, or the option C is your hypertension? Any one of you? So much lag in the live comments, almost about 25 seconds. I don't think so. Is the lag is there? As I think my audio is perfect. Is there any lag in the audio and video? Yes, seen in the Marfan syndrome. Exactly. Exactly. So much lag in the comments, almost about the 25 second. I don't think so. Is there is any lag? Now I'm getting answers. Very good. Very good, doctors. There is the your in this condition where we are seeing this, that is your what? Yes. Is it perfect, doctor? That is your hypertension. Perfect. So answer should be your what? Your answer should be in this condition, hypertension. So in the hypertension is the most common cause of your, this is the case of your aortic, the aortic dissection. Yes, it is all GDDD. Not in audio video, lag in the comments. I don't think so, doctor. There will be the lag in the comments. If there is some lag, okay, I will wait for you for your answering. Okay, I will wait for 20 seconds. Okay, I will wait for it. Okay, so this is the your aortic. Yes, this is the case of your aortic dissection. Okay, so this case, remember about this. This is the tannous wall appearance which is seen on the your aortic dissection. Perfect. So this is the your most common cause of aortic dissection is the your hypertension. Not it's related to your diabetes mellitus. Also the atherosclerosis can be the also can be the your risk factor, but not the most common. Not the most common. Okay, most common. The question is going to ask you about the most common risk factor. Okay, so the risk factor most common is your hypertension. So this is the also your aortic dissection. I already mentioned you, and the most common cause of this is the your hypertension. Okay, the most common cause is your hypertension. Sir, you are getting our comments after 20 to 30 seconds. No issue, doctor. I will going to wait for your comments now. After showing the MCQ, I will wait for the 20 to 30 seconds. I understood now. We are responding almost immediately. Comments delivering delayed. Happened day before yesterday as well. Okay, doctor. Maybe some issue with the some YouTube. Okay, from the YouTube end. Okay, I can understand your things. I will be going to wait for your you guys for the 20 to 30 second after showing you the MCQs. Okay, you have to reply. After the replying you only I will be going to clear out your doubts and everything. Okay, no issues, no issues, doctor. Okay. Okay, doctor. Okay, let's move forward for the next MCQ, which I'm going to show you on your screen. And this MCQ I shown you on the screen. Try to reply me in the now on the chat box. A patient with the pain in the right hypochondrium. The patient is coming to me for the right hypochondrium since the 3 days, and the patient went under the USG. And this revealed the given the picture is given in this condition. And now we are not asking about to you that what is the diagnosis of this patient. They are asking you about the what is the true about this image. They're talking about the true about this image, and the image is clearly given to you. The first of all, you have to identify what is this given in the diagnosis. Make the such diagnosis of this image. Then we're going to go for the MCQ. Just try to first of all uh, just try to go with the your first we'll go with the diagnosis, the making the diagnosis of this MCQ. Just go with the diagnosis of this. Sorry for this. Now tell me guys, what is your diagnosis in this condition? This USG is shown to you. Sorry for the disturbance. Okay, posterior shadow, you are asking question mark or telling me. Very good. Gallstone, yes, gallbladder stone. Agree with you. Okay, let's talk about it. Let's talk about it. So what I'm going to see in this condition, you can see here that something is here. This one and this thing particularly is giving some acoustic shadow also. Can you identify this acoustic shadow? Yes, can you identify this acoustic shadow? Yes, can you identify this acoustic shadow? Let me know in the chat box. Can you identify this acoustic shadow which is seen to you? Yes. Now, of course, doctor. And this is the case of your gallbladder stone. This is the case of your gallbladder stone. Yes, this is the case of your gallbladder stone. Yes, doctor, it's gallbladder stone. Okay, gallbladder stone. Now, you made the diagnosis, it's good, but now we have to go with the MCQ. Now tell me, what about the MCQ is asking? This is asking about you. What is the answers? So the option is given to you. This is the indicate posterior acoustic enhancement. No, it is not seen to you. The secondly, they are asking you likely to be a renal caniculi. Is it the renal caniculi? No, we'd already diagnosed it that this is the your gallbladder. This is the patient's gallbladder. So option B is the not possible in this condition. Now moving forward for the option C, that this is indicate the posterior acoustic shadow, and option D is the your indicate none of the above the given. So option D is the not the possible is there. Thus only and only we are going to confuse with the two options, which is about the option A and option C. So please rule out about it. Option B is not the possibilities are there. Now we confuse with this. This is the increasing the posterior acoustic enhancement is there, or maybe there is the posterior acoustic shadow. Now tell me in the chat box, guys, what is it? Enhancement is there or acoustic shadow is there? Just tell me. Yes, the both options are given is the posterior only. Yes, very good, doctors. So I already shown you. I already shown you this is shadow. Yes, after this, as the, what is happening, this is the probe. From here, the ultrasound waves are coming. Okay, so ultrasound waves are turning to it and return back to it. Okay, return back to it. Okay, but what about this condition? Here it's clearly the audio. This ultrasonic waves are going directly. Okay, so that's why in this area there is the acoustic shadow is going to seen. So as the acoustic shadow is going to seen, so option C is the correct answer for this condition. Your option C is the your correct answer for this condition. Okay, is it clear to you, guys? Is it clear to you very well? So option C is the correct answer, that it indicate the posterior acoustic shadow. And of course, by the seeing the ultrasound, you identify this, that this is the your gallbladder stone. Okay, which is the gallbladder stone. Very good, doctors. Very good. Right? Should we move forward? Very good. Should we move forward? Now, moving forward, yes, answer is your indicating the posterior acoustic shadows. And yes, the calculi. Yes, of course, this the calculi in the gallbladder is causing the acoustic shadow, posterior acoustic shadow, right? So this is the calculi. This is the calculi. Guys, if the polyp was there, if the gallbladder polyp was there, then what will be the answer? If the gallbladder polyp, just I'm going to show you the gallbladder polyp also. I think I have the image of gallbladder polyp. Just give me a minute. Just give me a minute. I have to show you that gallbladder polyp. Yeah, I have that. Can you see this? Can you see this? Can you see this? What will be seen on the gallbladder polyp? Is there any acoustic shadow is seen to you guys? Just let me know. Any shadow is going to seen to you? Any acoustic shadow is seen to you in this condition, gallbladder polyp? No, there is a no shadow. Okay, so if in the gallbladder there is a something is seen to you, how to identify by the ultrasound? Is it your, yes, is it your renal, is it your calculi, gallbladder calculi, or the gallbladder polyp? So by the seeing the shadow, by the seeing the shadow, you can identify that this is the gallbladder stone or your gallbladder polyp. Okay, we're going to talk about this image. We're going to talk about this image in the last. Okay, so I will going to cover up this image also. Okay, about this acoustic shadow and no acoustic shadow. Okay, let's moving forward for the next MCQ, which is on your screen. Yes, this is about the polyp. Polyp will not show no shadow on the polyp. Okay, no acoustic shadow on the polyps. Let's move forward, and the next MCQ is in front of your screen. The esophagus on the barium swallow. There's a picture of the barium swallow on the esophagus, which is shown to you, and the image is shown you below. The image is shown to you below, and they're asking you about the diagnosis. What is this condition? It's a diagnosis. So make the diagnosis of this condition, guys. Guys, make the diagnosis of this condition. Try to make the diagnosis of this condition. I'm waiting for your answers. I can understand the 20-30 second delay is there in the comments. I will going to wait for you. Just try to reply. Then I will going to talk. So options are given to you. Option A is your DES, which is your diffuse esophageal spasm, and option B is your esophageal carcinoma. Option C is your esophageal ulcer, and option D is your achalasia cardia. Very good, guys. Now I can see your comments. I can understand. Yes, there was some delay was there. Very good, very good. So first of all, I hope you understand and you replied very well. This is the option A is the correct answer, because what we are seeing there, we are seeing the very classical image of your cork screw appearance. Yes, very good. We are seeing the cork screw appearance. Okay, I hope you know about it. Cork screw appearance. But first of all, tell me, what is the barium swallow? I want to ask you something different. What is this? I'm asking you this. Just tell me about in the chat box. What is the barium swallow? What is the barium swallow? I'm waiting for 20-30 seconds. No issues. Try to reply. Try to reply in the chat box. What is this test? Barium swallow. Ophthalmology RR is also requested. Doctor, we already had the ophthalmology sessions. Two ophthalmology sessions is already done on the Meduhub channel, right? So just go through that particular sessions, and also on the YouTube I already put it the rapid revision, which is the your ophthalmology quick recap. Okay, OQR is already uploaded there. You can watch that. You can watch that, doctor. Okay, about the ophthalmology we already done. Okay, if the requested, if you are going to request that also, we're going to take up one more session. Okay, but just watch that first of all. Okay, just watch that. Okay, so barium swallow is the your diagnostic modality of the esophagus motility. About the motility, we are not going for it. Just remember about it. For the esophageal anatomical or any disturbance we are going to do in this condition, guys, your barium is the your contrast material. Please understand this about this. Barium is your contrast material. Contrast material. And this contrast material, the patient, we are giving this contrast material to the patient for drinking it when the patient is having this, swallowing this. Okay, when the patient is swallowing this barium, so this is going into the esophagus, and then we are going to take up, when we are going to take up the x-ray of this patient. Okay, and this barium, which is the contrast material, is it clearly visible on the x-rays? Okay, this is the contrast material, so this will be clearly visible on the x-ray. So what is happening, as you can see here, so it is giving us the anatomy of, so is it clearly seen to, is it giving us the anatomy of the esophagus? So for the upper GIT, the upper GIT anatomical issues, we are doing the barium swallows. Okay, we are doing the barium swallow. And what about the barium enema, guys? Do you know about the barium enema? Barium enema. What about the barium enema? Do you know about it? Of course, for the lower GIT, we are doing the barium enema. Okay, so what we guys are doing in the barium enema, with the same barium, which is the contrast material, we are giving the patient from from the rectum, and then we are taking the picture of it. So I will going to show you. Yes, enema for the rectum. Yes, enema for the rectum. Yes, for the seeing the your large intestine and the colon. Yes, sigmoid colon, and yes, we are doing most commonly the barium enema is done for the your ulcerative colitis and the Crohn's disease. For the ulcerative colitis and the Crohn's disease, right? Sure. We'll be going to talk about the, I will going to show you the lag pipe sign in the ulcerative colitis, and surely we'll be going to show you in the barium enema. Okay. So please remember, if the barium mouth, and this will be for the upper GIT, and if the enema is word there for, this is for the lower GIT. This is for the lower GIT. Okay. So now tell me what is seen in this condition. Can you see this particular esophagus? It is coming straightly and then it is having a cork screw. Okay. So it is having such screws like this. Okay. So this is having the cork screw appearance. So this is your, yes. So it is having the cork screw appearance. Very good. Appearance. Okay. So this corkscrew appearance is the classical image of the corkscrew appearance is the classical image of your diffuse esophageal spasm. So answer is here your diffuse esophageal spasm. Your answer is your diffuse esophageal spasm. Okay, guys. Right, very good. Let's move forward for it. So answer is your diffuse esophageal spasm. Sometimes they are just giving you in the option D, E, S. So please remember this is your diffuse esophageal spasm. Okay. Sometimes they are not mentioning, the examiner want to confuse you. So they are not mentioning the full diagnostic name. Okay. Just they are mentioning the short name. Okay. So just keep in your mind that DES is the full form of your, the short form of your diffuse esophageal spasm. Right? Okay, let's move forward. Let's move forward. And now we are moving forward for the next MCQ. For that, the corkscrew appearance for the esophagus is for the diffuse esophageal spasm, which is your DES. We already covered about it. Now, let's move forward for the next MCQ. And this next MCQ is on your screen. The MCQ is there. Identify the image technique which is employed at the specific diagnosis related to the kidney. For this, I've given you the image and they want to ask you about that. Identify the image technique. Which image technique is used here specific for the diagnostic related to the kidneys, right? For this kidney diseases, they used this particular, and they want to ask you about the diagnostic also, right? They want to ask about the diagnosis also, and they want to ask you which imaging modality is used here. Doctor is saying the video is lagging. I don't think so. There is some lagging will be there because simultaneously I can read your comments on the my second screen. That is showing me clearly the video is perfectly going on. Okay. I don't think so, doctor. If there is a lag is there, please restart your YouTube once. Please restart your YouTube once. If there is some lag is showing you, or check your internet connectivity also. Just check it out your internet connectivity. I don't think so. There is some lag from my end. From my end, is going perfectly. Okay. If anyone is also feeling lag is there, so please let me know. Yeah, all are saying this is going perfectly and good. Just check your doctor. Doctor, check your internet. Just once check your internet from your end. So what is your answers, guys? Please reply me in the chat box. A, B, C, or D. So options are given to you. Option A is here for the MRI of your polycystic kidney disease. Option B is your CT of the polycystic kidney disease. Option C is here for the MRI for the horseshoe kidney. And option D is your CT for the horseshoe kidney. So the first of all, I'm going to clearing you out that this is not the horseshoe kidney. Is it not possible that this is the horseshoe kidney? Because we already know in the horseshoe kidney what is happening, guys. This both kidneys are will be going to attached together. Yes or no? So this is not the horseshoe kidney. So just wait for it. I'm going to show you the image of horseshoe kidney. Just a minute. I'm entering one more image. Horseshoe kidney. Right. And showing you the image also. How this is horseshoe kidney is seen. Can you see this image? Can you see this image? Just check it out. Then we'll be going to remove that. This is the both of the kidneys are there, and this is making attachment. Can you see? This both are attached here. This both are attached here. Okay. Is it seems there is the kidneys are attached? Is it seems here? Is the kidneys are attached here? Yes or no? Yes or no? Not possible. Yes, not possible. And also, if I'm talking about the horseshoe kidney, in the CT scan of horseshoe kidney, I'm showing you. Just please let me know in the chat box. Is it the horseshoe kidney? The same are seen there? Yes, fusion of the kidney will be there. Okay, the fusion of the kidney. Yes, it's clearly not the. Yes, it's clearly not the. It's okay. So no attached is there. Okay, and also if I'm talking about the horseshoe kidney image, just please remember about it. If I'm talking about the clearly image of horseshoe kidney, the radiological image, just wait for it. So you can see this radiological image. You can see this radiological image that this both kidneys are attached here. Okay, this both kidneys are attached here. Can you check it out? This image. Can you check out this image? Yes, you can make the clear diagnosis. This is not the horseshoe kidney. So this is what? This is your polycystic kidney disease. What is this answer? Polycystic kidney disease. Now, I agree with you, but the options which are getting confused here, sir, is it the CT scan or is it the MRI? Yes. So this is the particularly which I'm showing you here about this horseshoe kidney. This is the CT scan of horseshoe kidney. Okay. So this is the kidney, horseshoe kidney. This is the CT scan. So I'm removing it. Just wait for me. I'm erasing it. Okay. So this is not the horseshoe kidney. I agree with you. So what is the answer? Answer is, sir, here polycystic kidney disease. This is the polycystic kidney disease, PCKD. But now my question to you guys, is it the MRI or is it the CT scan? Three time, yes, yes, yes. Horseshoe kidney was three time MCQ. I agree with you. Jan 23, July 23, Jan 24. Three time MCQs. Okay. Back to back horseshoe kidney is coming from the radiology. Okay. I already shown you the image. Also, we have the later also image of the horseshoe kidney. I will be going to show you. No issues. Okay. Just let me know. Just let me know. Is it the CT or the MRI? Just let me know. Very good. As you are answering very well, I'm going to cover up here both of the image and then I'm going to cover up the things which is clearly seen to you. I'm putting the both of the images and then I'm going to ask you about it. Now tell me, this is the image A, this is the image A, and this is the image B. Now tell me, sorry, I made the difference. This is the image B. This is the image A. Okay. Yes. Now tell me, which is the CT, which is the MRI? Now I think you can diagnose it clearly. Which is the CT, which is the MRI? Which is the CT, which is the MRI? Very good, doctors. Very good. Which is shown in the MCQ? Which is shown in the MCQ? That is the MRI. That is the MRI. And which I put it the image, which is the image B is there. That is your CT scan. Sir, how you identify that this is the CT scan? You already know in the part 1 of radiology. I already told you that CT scan we are using which rays are used in the CT scan. Just let me know. Yes, A is the MRI, B is the CT. Very good. Which is the option is given. I already put it with the same. This the diagnosis of this image also. The diagnosis of this image also the polycystic kidney disease. PKD is only there. You can see this is the kidneys and it is having the cyst are over there. Okay, on the both side. This is the bilateral. This is the bilateral. I agree with you. Just let me know. Just let me know in the CT which rays we are using. In CT scan, which rays are using. Reply my answer. Please reply my answer. Which we are using which rays in the CT. CT is just the multi-axial X-ray. Very good. And now tell me on the X-ray, the bone is seen white. Yes or no? We saw the many X-rays here. We saw the many X-rays here for the chest, thorax cavity. We saw this, and you can see this is the bones. Yes, this is the vertebra. Yes, vertebral column is there. These are the ribs. Can you see these ribs are seen white? So this is your CT scan, and the over of it, can I see here? This is the vertebrae, and these bones are not seen white. Can you identify now? This is not seen white on the MRI. Yes. So on the MRI, what I can see on the MRI, this is cyst. On the MRI, the cysts are seen more whitish, or we can say the hypodense. Yes, hyperdense. Okay, hyperdense. The cysts are seen, or rather than on the CT, I can see these are seeing dull. The cysts are seeing the dull. Yes. Can you identify now? Right. So what should be the answer of this? Yes. The answer should be here. Your answer should be here. The MCQ which is showing you this image. This is the MRI of your polycystic kidney disease. Is it clear, guys? So this is the MRI of your polycystic kidney disease. Is it clear to you guys? Just let me know yes or no. Then I will going to remove this image. Then I will going to remove this CT scan image which I put it here. I hope now is it clear to you differentiation between the CT and the MRI. Yes, I hope is it clear to you, and you can identify now the CT and the MRI. Should I remove this image of the CT scan? Should I remove this image of the CT scan? Let me know in the chat box. Let me know in the chat box. Yes, very good. So what should be your answer in this case? Your answer should be in this case. Answer is the A. Your answer is in this condition is the A, which is your MRI of the polycystic kidney disease. Okay, so answer should be your polycystic kidney disease. Very good. Should we move forward? Now we are moving forward. Please remember horseshoe kidney. I shown you the CT scan of horseshoe kidney. Remember about that. The CT scan of the horseshoe kidneys are coming back and back. Okay, I will show you in the later part also. We have one slide of that image. Okay, let's move forward. And this cysts which are seen on the polycystic kidney disease are the non-cancerous. These are the sacs which is containing the water-like fluid, and you already know the fluid will be going to seen white on the fluid is seen more white on the your MRI, and that's why they grow very large. They grow very largely, right? So this is about the polycystic kidney disease. Now let's move forward for the next MCQ, and very important MCQ is here, which is the more chances to come in the your exam. So the MCQ is in front of your screen that is asking you which tissue is over body is the most sensitive to radiation. Now tell me, the options are given to you: skin, option A is skin, option B is the muscle, option C is the bone marrow, and option D is the nervous tissues. Now I'm waiting for your answers in the chat box. Please try to reply me in the chat box. What should be your answers in this condition? What should be your answer in this condition? So they're asking about the radio sensitivity. It means which will be going to having more harm. Many of are replying A, skin. Many of are replying the C, bone marrow, and many of are replying D also, nervous cell also. Okay. So doctor is saying, sir, rapidly dividing cells regions are yes, sir. Also, I can agree with you. Some of are replying the neurons, which is the nervous tissue. Guys, please don't think about it that nervous tissue are rapidly dividations. Neurons are not the rapidly dividations. Okay. Let's talk about it. Let's talk about it. So they are asking about the in our body, which is the most radio sensitive to the radiation sensitive areas. So guys, please remember the radio sensitive areas are there such which are more having the rapidly growing of the cells. Also, should our skin is having the rapidly growing of the cells? No, our skin turnover time is your 56 days. Yes, our skin, yes, our skin turnover time is your 56 days. Also, the muscles will be having the not too much growing of the cells. All right. But please remember about the bone marrow, where our blood, yes, our blood is getting more rapidly. Yes, our blood is making there. So we have inside the bone marrow, we have the pluripotent cell. potent cell and unipotent cell. Yes, these potent cells are further dividing and giving us the RBC, WBC production and the platelets. Yes, and this RBC, all the five type of RBC, neutrophils, eosinophils, basophil, and your lymphocyte and monocyte. All the type of your WBCs are also dividing from there only. So please remember which is the stem cell. Yes, exactly. That is the stem cell in the bone marrow, and stem cells having the cells which is the pluripotent and unipotent cell. Yes, the stem cell is having the pluripotent and the unipotent cell. So that are more radiosensitive because they are having the rapidly dividation. So I have the rapid dividation of these cells. So these are the stem cells of the bone marrow are the most radiosensitive. Now my next question to you, is there any other of the more radiosensitive organ you know about it? Just let me know in the chat box where we have the more rapid. Guys, the nervous tissue is not having the rapid dividation. Please remember, the nervous tissue will be not in the most radiosensitive. Which is other than the bone marrow where we are having the rapid cell division? Rapidly cells are going to dividing there. Just let me know. Just let me know. I'm waiting for your answers. Which are the regions where we have the rapidly dividing cells region in the body? Just let me know. I'm waiting for your answers, guys. Very good. Gonads. Yes. Ovaries. Testes. Right. Of course, there are also the rapidly growing the cells. Yes. In the ovaries and the testes. So yes, the answer should be your gonads. Gonads also. Yes. What about other than the gonads? What about your answer should be other than the gonads? Other than the gonads? Other than the gonads? Least. Yes. These are the moreover. And please remember skin and hair also. Skin and hair also, but they are the least radiosensitive. They are also the radiosensitive, but least. We are talking about most sensitive. So bone marrow and the gonads are there, which are the more over of it. Okay. So your answer should be in this condition is the bone marrow. And we already know about it. The cells of the bone marrow are proved highly radiosensitive. Highly radiosensitive in this condition. Is that clear to you guys? Is it clear to you guys? Should we move forward now for the such images? I think the important MCQs we had already covered there. Now we are going through the some important images related to your radiology, and then we'll be going to finish this session. Okay, right? Okay, let's start, and please reply me in the chat box fastly. Whatever the images I'm going to show you, please specifically give me about the name of that particular sign if you know about it, the name of the sign, and if the name of sign is written there, please reply me the diagnosis of that particular thing. Okay, so reply me the diagnosis if the sign name is given. If the diagnosis is given, then reply me the sign of it. So we are moving forward for the next, and I'm showing you the first of it. Sad, this is your patient, which is the newborn is there, and there is a patient is having the congenital diaphragmatic hernia. So the patient is having the congenital diaphragmatic hernia. Now tell me what should be. Now tell me what should be the your. Now tell me what should be the, your sign is seen to you. What should be the sign? Yes, this is the congenital diaphragmatic hernia. Which sign is it? Which sign is it? In the congenital diaphragmatic hernia, which sign is seen? Which sign is seen, you guys? Let me know in the chat box. Which sign is seen, guys? What is the name of this sign? Yes, Broadcheck hernia. Agree with you. Yes, you can say the soap bubble appearance is also, you can say this thing. But there is a what? There is a bubble and or the intestine which is in the lungs, yes, and the thorax, right? So the intestine or the your will be going to move up above from it, congenital diaphragmatic hernia. So this will be going to seen in this. Yes, yes, not sure. It is not the answer. But what is happening in this condition, you can see here. So this is the intestine. And what is the confirmatory for this? How we are going to confirm this? How we are going to confirm this? Can you know about it? How to confirm this congenital diaphragmatic hernia? By the investigated, what we you can see here, we put it the nasogastric tube. When we are putting this nasogastric tube will be going to find inside the thorax cavity. Yes, we're going to find the nasogastric tube, NG tube. Yes, yes, intestinal loop will be going to seen in this in the erect abdominal X-ray. And when we are going to pass the nasogastric tube in this newborn, when we are putting this nasogastric tube in the patient, so this nasogastric tube will be not going into the abdominal cavity. This will be going to reach, yes, NG tube will be going to reach inside. This NG tube will be going to reach inside into the, thus reach into the thoracic cavity. So this is the case of your congenital diaphragmatic hernia. This is the case of your congenital diaphragmatic hernia. Now, moving forward, for now here, this is your pneumoperitoneum, which is your football sign. Yes, pneumoperitoneum, we talked about it, which is the gas or the air below the your diaphragm. So you can see this is the your diaphragm which is above it, yes, and it is pushed above, right? So this the patient is having the football sign. This is known as your football sign, and this football sign is seen in the newborn. Okay, in the newborn we are seeing the football sign in the pneumoperitoneum. Pneumoperitoneum, is it clear? So this is the football sign from the pneumoperitoneum. Yes, very good. Now, moving forward for the next image, this is seen to you, and this is the image of your coarctation of aorta. And now tell me, what is this sign? What is this sign? First of all, where I marked with the red color of arrow. First of all, tell me what is this three sign? What is this sign? Sorry. What is this sign? What is this sign? This sign is known as your three sign. Can you see? This is the, we are seeing the three is there. Yes, it is looking like the letter three. Yes, it is looking like the letter three. So it is known as the your three sign. This is known as your three sign. And this is the only the three sign. Now tell me, what is this blue color markings? This blue color markings is what? What are this such the blue color markings? What are the blue color markings? What are the blue color markings are there? Yes, very good, very good. So we have this blue color markings are the, you can see this is the your inferior rib notching. Yes, this is what? Yes, doctor, this is your, this is the your, yes. So you can see from the in for the inferior side, your rib is getting notched. Yes, so this is known as your inferior rib notching. This is known as your inferior rib notching. Very good, doctors. So this is about the your, this is about the your disease, which is the your coarctation of aorta. So this is the X-ray of the patient from the coarctation of aorta. Now, moving forward for the next one, which is the your tetralogy of Fowler, and I hope you know about this tetralogy of Fowler very well. Yes, you know about this tetralogy of Fowler very well. What is this? Yes, this is the top, which is the boot shape sign, which is the boot shape sign. Okay, boot shape heart. So I'm going to show you one more image we are having for the same your this condition. I'm going to show you for the tetralogy of Fowler. We have the two images. Just a minute. Just a minute, guys. Can you see this? This is the boot-shaped heart. You can see this is the boot-shaped heart. Yes, very good. So this is seen in the tetralogy of Follett. Tetralogy of Follett. So you can see now identify there is a boot is there. Yes, you can see this is the boot. This is the boot. Yes, so the same looking like the boot is in the inside the heart. So this is the boot. Okay. So one more image which was above there, we had this one. So I can identify you the boot here. So you can see here, this is the boot. Okay. So the boot shaped heart is seen in your pathology of Follett, which is a congenital, disease. Yes. So this is your congenital disease. Yes. Very good. Yes, mostly the second and third rib notching will be going to seen in the coarctation of aorta. Agree with you, doctor. Agree with you. That's why they are marking of the second, third rib only. Okay. Mostly they will be seen in this only. Okay. Very good. Should we move forward? Should I move forward? So we're done with the coarctation of aorta. We're done with the tetralogy of Follett. So please remember, this is the boot-shaped heart. Right? So this is the boot-shaped heart. Okay. This boot-shaped heart. Okay. Let's move forward. Let's move forward. This is the next. We have one more important sign you have to remember from the ENT purpose, right? From the ENT subjects, you have this seen in the mode in the congenital from the children X-rays, and this is the your thumb sign, guys, which is seen in the your. This is the your thumb sign. This is the thumb. Yes, it's looking like that. Someone putting thumb here, right? So this is the your thumb sign, and this thumb sign is seen in from your acute epiglottitis. Your thumb sign is seen from your acute epiglottitis. Your thumb sign is seen from your acute epiglottitis. Okay, should we move forward? Yes, acute epiglottitis, which is seen in the thumb sign. Thumb sign, acute epiglottitis. Acute epiglottitis. Let's move forward. Let's move forward for the next image, and the next image in front of you, which is your single bubble sign. Yes. So the image which I shown you there, where there was a multiple bubbles was there, but can you identify in this condition there is the one single bubble is seen on the erect abdominal X-ray. Can you see this thing? Can you see this thing? Can you identify this single bubble? And please remember, when you are identifying, there is a one bubble only seen in the air. Okay, one air bubble is seen only. So what is the cause of it? This is the congenital hyper. Yes, it is a congenital hypertrophic pyloric stenosis. So what is the pylorus pars? Your hypertrophic, your pylorus part of the your stomach. It is getting your congenitally stenosed, very narrowing of it, and due to this, there is a gas will be not going to pass through the intestines. So that's why there's the gas will be remain into the stomach only. And when we are taking the erect abdominal X-ray, what we are finding? We are going to finding there that the patient is having the single bubble sign. So the patient is having the single bubble sign. So please remember, the patient is having the diagnosis of the congenital hypertrophic pyloric stenosis. Okay. Okay, is it clear about the single bubble? Very good. Now, please remember, there was the only one bubble. This only the one single bubble. Now we are moving forward for the next one. As I can see here, this is what? This is the your double bubble sign. And identifying this, I can identify you one bubble, which is this, which is the stomach, right? You can see here, this is the number one bubble, and this is the second bubble, which I can see over here. And what is this second bubble? Your second bubble is the your duodenum. Yes, so you can see here, now there is a no in the. Yes, 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 yes. Very good, doctor. Very good. Single bubble, pyloric stenosis. Double bubble will be seen in the duodenal atresia. Duodenal atresia. Because what is happening, the duodenal will be getting attracted, right? So what is happening? The air which is passing through from the stomach, it's reached to the duodenum, but the distal duodenum is not open there, right? So this duodenal atresia In the duodenal atresia, we are going to see the double bubble sign. This is the duodenal atresia. We are going to see the double bubble sign. So you can see here we have the two bubbles are there, which is the double bubble sign. Is it clear? Is it clear, guys? Now, very good. Now moving forward for the next image, which is the your triple bubble sign. And in the triple bubble, guys, again on the X-ray you can identify there is the three bubbles will be going to see. And how this is the three bubble? This is the stomach one. Okay, this one the stomach one only. Okay, one bubble. The second bubble is from the duodenal bubble. Okay, and the third bubble is from the jejunum. Okay, so this is the 1, 2, and the 3. So the three bubbles are seen there. So this will be the your triple bubble sign. So please remember now in a one one table, please mention this single bubble sign, your clone, your yes, remember about it. The single bubble sign, there will be the congenital hypertonic, your pyloric stenosis. So pyloric stenosis will be the single bubble. Your double bubble will be the your duodenal atresia, and the triple bubble will be your jejunal atresia. So when in the jejunal, your jejunum will be getting atresia, so there will be seen the your triple bubble sign. So remember this all the three: single bubble, double bubble, and triple bubble sign. Is it clear to you, everyone, about this all the three images? Is it clear to you about all the three images of the GIT atrasias, which is the single bubble, double bubble, and triple bubble? Okay, very good. Should we move forward, guys? Now, moving forward for the next one, this is the image of your Jenker's diverticulum. What is the mean of Jenker's diverticulum? Please remember, when we are giving the patient barium swallow, as the patient is having the barium, the patient will be swallowing this barium. So what is happening? There is the outpouching is seen here. And this outpouching is known as your Jenker's diverticulum. What is this known as? Yes, this outpouching of this your esophagus is known as Jenker's diverticulum. Is it clear? So this Jenkers will be there, right? So Jenkers will be going to seen here, right? So this is the outpouching of the, yes, which muscle? Very good. Inferior constrictor muscle of esophagus. Very good, doctor. So this is the outpouching of esophagus. So you can see where in this condition, what will be going to see, the patient is having the regurgitation of the food particles. Yes, after the having the food, what is happening? This food will be going to accumulated here. Can you see? If the patient is having the food, this food will be going to stay there. And after the some time, when the patient is lying down, this food particles is coming back again. So this is known as the regurgitation of food particles. This is known as the regurgitation of the food particles. And what is the location of this? Yes, very good. Between the thyro and cricopharyngeus muscle, we are having to see this particular outpouching. Yes, yes. Halitosis will be, of course. Very good. Now the patient is having the food particles is coming out, so we'll do the barium swallow. Yes, on the barium swallow we'll be going to on the barium swallow there is a regurgitation. Of course, regurgitation history will be there. So we'll after the regurgitation history, we're going to ask the patient. We're going to ask the patient to do the barium swallow investigation. On the barium swallow, we'll be going to found this Jenker's diverticulum in the outpouching. Yes, so if outpouching is seen on the X-rays in the barium swallow, yes, on the investigation of the barium swallow. So this is the case of your Jenker's diverticulum. This is the case of your Jenker's diverticulum, right? Now moving forward, one more is there, which is your PYQ, repeated PYQ, guys. Okay, repeatedly coming your PYQ. I think 3 to 4 times they asked you the same question, which is your bird beak appearance, and this is the case of your achalasia cardia. Yes, I hope you know about this very well. This is your previous year question, and this is the repeatedly time they are asking you about it, which is the achalasia cardia. Now, what is happening in the achalasia cardia? You know already, right? Yes, you know about it. In the bird beak appearance, what you guys are seeing, this is also the case of your barium swallow. Yes, and and you can see here In this case, when this is the esophagus which is dilated there, and you can see after all the barium will be accumulated there. There is a scene of the narrowing of the esophagus. Can you see? This is the narrowing of it, and it is, seems like that there is a bird beak is there. So you can see this is having only the short part. Please remember, this is having the very short, you can see narrowing. This is having the short narrowing. We're going to ask about one long and narrowing also, that is the your CA esophagus. So there will be the short and narrowing, which is like a bird beak. Yes, so we have the bird beak. Yes, like that. We have the bird. Okay. So this is the bird beak. This one, bird beak appearance. So we have the bird's beak is there. Yes, so this is the bird. Yes, so we have, this is the bird. So this bird is having this beak. So this is the bird beak. Yes, this is having the bird beak appearance. Okay, this is the patient, the bird beak appearance, which is seen in the achalasia cardia. So bird beak appearance will be seen on the achalasia cardia. Yes, rat tail is different, doctor. Rat tail is different. Please remember, rat tail I am going to show you now. Rat tail is totally different. Just think about it, about the bird beak. Rat tail will be in the your cancer esophagus. Just next image I'm going to show you. Just remember, if the beak is there, I already drawn one small bird there, right? So you can say the bird's beak is very short, right? Shorter. So that shorter of the your narrowing is very shorter, and the narrowing will be always digitally, right? The lower part of the esophagus is having. Yes, difficulty in more for the liquid more than the solid will be seen. Yes, of course. But now I'm going with the next one, which is the esophageal carcinoma. There will be the rat tail appearance, and you can see the same. This is the your barium swallow, and you can see this is the narrowing is very broad. Can you see? This is the narrowing very long, and it's looking like that. That this is the rat, right? This is the rat, and this is having the tail of the rat. We are having the tail of the rat. Is it clear to you, doctors? Now, okay, right? So pencil tip for the glacier we cannot say, because the pencil tip is the totally sharp. You know, pencil tip is totally sharp, right? वो कैसा होता है pencil tip? Pencil tip is like that. Okay, so ऐसा नहीं होता है in the your achalasia. The achalasia is having like that. Okay, having like that. Okay, bird beak. Okay, so that's why the name is given as the bird beak appearance. Okay, but what about the your pencil tip? Pencil tip, I will going to show you the steeple sign. I hope you know about the Krupp steeple sign. The Krupp steeple sign is your clinical significance, or the clinical the clear of the pencil tip sign. Okay, which is the steeple sign, is also known as the steeple sign. So please remember, in the esophageal carcinoma, we're going to see the rat tail appearance, and rather than in the your achalasia cardia, we'll be going to see the bird beak appearance. Is it clear? No confusions? No more confusions? No more confusion, guys. Please remember, achalasia cardia, bird beak. Okay, this bird beak. Okay, so bird's beak appearance. Okay, so and the red tail will be going to seen. The red tail will be going to seen in the esophageal carcinoma. The red tail will be going to seen in the esophageal carcinoma. Is it okay? Is it okay, guys? Perfect. Now moving forward for the next one. The next image is your aortic dissection, which is your crescent sign, or you can say the tennis ball appearance. Just a minute, guys. Just a minute. Sorry for this disturbance, guys. Sorry for this disturbance. Right. Okay. So we are talking about this. This is the kind of the crescent sign. You can see some crescent is seen on the your aorta, and also I can see there. I can see the tennis ball sign. What I can see there, I can see in the aortic dissection. We can see the tennis ball sign. We can see the tennis ball sign. Okay. So this is the scene in the your. This is the scene in your aortic dissection, right? Aortic dissection. So the image of aortic dissection, you can see that is the your sternum. I already shown you in the image, right? And the question, the same image was put it there, right? And this is the your vertebrae, and this is the your aorta. So you can see the aorta is having the dissection here. Yes, it is splitting here. Okay, so this is your tennis ball sign. It is not looking like that. It's looking like the same tennis ball, right? So our tennis ball is having the white strips there, right? Green color is the ball, and we have the strips over it. So it's looking like the same. Okay, this is the tennis ball sign. Now moving forward for the next one, which is your drooping lily sign. Guys, this was the question which was I asking you, and this is the case of your IVP. Yes, intravenous pyelogram. Okay, intravenous pyelogram is given to you, and you can see this in the intravenous pyelogram. What will be going to see in your, this will be going to see in your drooping lily sign, right? And this is the duplication of urinary calcareal system. Okay, there is a duplication of urinary calcareal system. So drooping lily sign will be going to seen in this condition. Drooping lily sign will be going to seen in this condition. So this is the your drooping lily sign. Okay, this is looking like that drooping lily sign. Okay, right? So this is the drooping lily sign. Moving forward for the next image, which is the from your skull image, which is your multiple myeloma. This is also the PYQ repeatedly coming image, which is asking you raindrop sign, which is asking you about the raindrop sign. It is looking like that on the skulls. We are finding some small drops are there, which is the raindrop sign. Guys, please don't be confused with the salt and pepper sign. On the salt pepper sign, what there is a total big black colors images will be going to seen, that is seen in the your hyperparathyroidism. Okay, here you can find out there is a punch out lesions are seen. These are the punched out lesions are seen in the multiple myeloma. The punch out lesion are seen in the multiple myeloma. Is it clear? So don't be confused with the, yes, the raindrop sign and the punch out lesion are seen on the your multiple myeloma, rather than if there are the we can say the salt and peppery appearance that is seen in the salt pepper appearance will be going to seen in the your hyperparathyroidism. Now moving forward for the next, which is for the thalassemia. And the thalassemia, we are finding the hair on end appearance. You can find there are the hairs on the end of skulls, right? There are the hair and appearance, and this is seen in the patient of thalassemia. Next, which is the lung abscess, and this is also a crescent sign, right? This is your lung abscess. Okay, this is the your lung abscess, which is the crescent sign, right? This is the your pencil tip sign or a stipple sign, which you are asking, doctor. So you can see this is the tip of pencil, you can say. Yes, this is the tip of pencil, you can say right here. Okay, so this is the pencil tip sign. This is the pencil tip sign. Also, you can say the crescent, your steeple sign. Yes, this the name is the steeple sign, and this will be going to seen in your acute laryngotracheal bronchitis, which is your group. Now, the more images which we are having over there, I'm going to cover up from the below, which is the more important images are there. So one by one, I'm going to cover up. You can see here, what is this image, guys? This is the image of, yes, this is the clinical image of your very important images I'm going to show you after this. Please try to understand this thing. CNS images are moreover important, which is nowadays they're asking you related to the CTs of it. So which CT I'm going to show you here, you can see this is the pneumosyphilis. What is the CT of this? This is the case of pneumosyphilis. Guys, what is the mean of this pneumosyphilis? Can you see, can you find out this air which is seen in the brain? Yes, can you find out this black color air which is seen on the CT? Guys, this is the CT scan, the first of all. Why it is the CT scan? Can you identify this bone is seen, this skull bone is seen is the bright white? Yes or no? So this is the bright white, and this is the dark area which is we are having the air over it. What we are having here, this is the air. Okay, so this is the air. Okay, this is the, we are having the air. Air is there. Okay, so this is known as your pneumo, which is the air syphilis. So the air inside the brain is known as the pneumosyphilis. So there is known as pneumosyphilis. So please remember about it. If they are giving you such image and asking you about the diagnosis, so this is your pneumosyphilis. This is the case of your pneumosyphilis. Now, moving forward for the next one, which is your types of hemorrhage. The first, which is your acute intrapharyngeal hemorrhage. So inside the your parenchyma, inside the parenchyma of the brain, can you see this is the more white part which is seen to you? It is the your bleed part. or you can say this is the hemorrhage. This is the hemorrhage, and this hemorrhage is seen in the inside the your parenchyma of the brain. So this is the your intra. Yes, this is the acute. Acute it means for the sudden onset of this. There is the not the chronic will be hemorrhage will be not the chronic. So it will be the suddenly intra the parenchymal. So intra parenchymal hemorrhage will be seen on this CT scan, and you can see out there. This will be this hemorrhage is pushing this brain. This pushing brain towards the again side, right? You can see out this. This is looking like that. This the hemorrhage is pushing the brain. Yes, pushing the cerebrum, right? Pushing to the towards. It is not to the midline. Yes, you can see it is away from the midline. This is the midline of this. Yes, so it is pushing away from the midline. This is pushing away from the midline to it. Yes, yes, very good. Yes, very good. So this is about the intraparenchymal hemorrhage. The next we are having the subarachnoid hemorrhage. Subarachnoid hemorrhage, SAH. Please remember the short names also. And by this also you can see this is the circle of Willis is clearly seen to you in this case. Yes, this is the circle of Willis is seen to you, and you can see this is the site of hemorrhage. Can you see here? Here, this is known as your subarachnoid hemorrhage. This is your SAH. So this is the subarachnoid hemorrhage. Can you see here? So this is the brain blood supply. As you already know, the circle of Willis is seen, right? So this is the, yes, Barry aneurysm rupture. Very good. So this is the your subarachnoid hemorrhage. This is seen in the your subarachnoid hemorrhage. This is seen in the case of your subarachnoid hemorrhage. Now, with the subarachnoid hemorrhage, we have the one more there, which is your subdural hemorrhage, which is known as your SDH. Yes, subarachnoid SAH. Then we have the SDH, subdural hemorrhage. And this in this subdural hemorrhage, you will be going to find out. You will be going to find out the this banana sign. Can you see? Okay, so this is kind of banana which you can see over there. So this is kind of banana which you are seeing here. This, okay, so this is the banana sign which will be going to find there. Yes, so this banana sign will be going to seen this banana sign. Okay, this banana sign. Yes, crescentic appearance hemorrhage you can say, or you can say the banana sign. Yes, as yes, yes, banana. You can say the banana also. You can say the crescent sign also. The both are the same. Okay, crescent sign or the banana. Yes, yes. History of the bathroom fall can be seen there. Also in the EDH also. Yes, extradural hemorrhage. There is a cricket ball injury can be seen. Right. Very good. Now moving forward, the thunderclamp headache will be going to seen in the your subarachnoid hemorrhage. Okay, subarachnoid hemorrhage. Now moving forward for the subdural, now we have the last one, which is your epidural hemorrhage, and this epidural hemorrhage, EDH, the epidural hemorrhage, we are having here Laman sign. Can you see? This is the kind of Laman. Yes, Laman sign. This is the Laman sign. Can you see? This is the image clearly seen to you that one Laman is over there. Yes. So bulging of, yes, from the bridging of the vein. And this is having a clear history of, the clear is history of in the EDS, the patient is having the clear cut history of the cricket ball injury, or maybe the this rod injury. Yes. Iron rod injury, cricket ball injury should be there. Yes, biconvex will be showed there, right? And the patient is having what? The cricket ball injury should be there, and the patient is having the iron rod injury should be there. Guys, please tell me what is the classical clinical feature of EDH? What is the classical clinical feature? Can you tell me about the clinical features of EDH? Do you know about it? The classical, very good. Mid-meningeal artery. I agree with you. MMA. Guys, tell me what is the classical clinical feature? Yes, very good. Lucid interval will be going to seen there. Yes, what is the lucid interval? The patient is having this injury, so the patient will be the unconscious. Then the patient is having the consciousness, and again the patient will be going to unconscious. So this the interval between this unconscious and this unconscious, which the conscious time was there, that is known as your lucid interval. That is known as your lucid interval. So between the two unconscious time, when the patient is having the consciousness, that is known as your lucid interval. That is your lucid interval. Now, talking about the next one, this image which is seen to your, yes, unconscious, then unconscious. So as the patient has had the cricket ball injury, he got unconscious, again he wake up, okay, so you get consciousness. So this consciousness is the lucid interval, okay, and again the patient is having the unconsciousness. So this between two unconscious, please remember, between two unconscious, the time is there, which is conscious time was there, that is known as lucid interval. That is known as your lucid interval. Now the image, yes, very good. Now the image you are seeing on our the screen, this is your gallbladder stone. We already talked about it. The gallbladder stone are giving us the posterior acoustic shadow is given. This is the posterior acoustic shadow is given to you, rather than I shown you already the gallbladder polyp is there. This polyp is giving no shadow. Can you see? There is a no shadow is given. So if no shadow is there, that is the your polyp. That is the your polyp is there. Is it clear? That is the your polyp is there, not the gallbladder stone, not the gallbladder stone. Moving forward for the next image, which is seen to you, this is the classical image of your hydrated cyst. This is the classical images too of your hydrated cyst, okay, right? So this is the hydrated cyst. Can you name the sign of the hydrated cyst? Can you name the radiological sign of hydrated cyst? Waiting for your answers. Hydrated cyst. Can you name it? Very good. Water lily sign. Very good, doctors. This is the your water. Perfect. Perfect, doctors. This is the your water lily sign. Perfect. Let's move forward. Let's move forward. Some more GIT images we left, right? So let's talk about such more GIT images. So starting with the first one, which is your diffuse esophageal spasm. We talked about in the image. Yes, DES. We already covered. You can see this is having the corkscrew appearance. So this corkscrew appearance is the your diffuse esophageal spasm. The next we have the Crohn's disease. In the Crohn's disease, you can find out string appearance. Can you see this string appearance? This narrowing of is, this is known as a string appearance, and this sting appearance is seen in the your Crohn's disease. Yes, so in the Crohn's disease, what we'll be going to find on the Crohn's disease, we'll be going to find the sting appearance on the string appearance. All right, so this is the Crohn's disease classical image, string appearance. After this string appearance, we are having the ulcerative colitis image, and in this ulcerative colitis, what we are finding, can you see this clinical image? This is seen as the lead pipe sign. Okay, this is known as your lead pipe sign. Okay, so this is the lead pipe sign which is seen on the your, yes, apple core I will be going to show you. Apple core is totally different. I'm showing you. This is the lead pipe sign which is seen in the case of ulcerative colitis, right? Ulcerative colitis, lead pipe. Okay, lead pipe. Now there is your apple core appearance. Can you see? This is looking like that. This is the apples, and this is the core of the apple. Okay, this apple core will be going to see this the same the image. Can you see this apple is written from here? Yes, so this apple core sign will be seen in the CA colon. So this apple core sign will be going to seen in the your carcinoma of colon. Is it clear? Apple core is the carcinoma colon. Is it clear, doctor? Now perfect. Okay. Okay, doctor. Very good. Right. So this is about the your CA colon, carcinoma of colon, and this will be going to seen in this condition. Is it clear? Very good. Very good. One more ultrasound image which I am going to show you here, which is the case of PCOD. And in this condition, we are finding the necklace of pulse appearance, which is your PYQ. Yes, This is your PYQ, previous year question. And in this condition, the PCOD, we are finding the necklace of pearl appearance. So you can see these are the follicles. Yes, and it is having the appearance of the necklace pearls appearance on the ultrasound of the ovaries on the PCOD, polycystic ovarian disease, polycystic ovarian disease, right? So that's it for the all the important image, guys. Thank you for joining this session, and we have a good session. We covered all the important images of the radiological perspectives, and covered almost the important part of the radiology, which is the high yield topics and which have the chance to come on your 12th January FMGE exam. All right, so that's it for today, guys. If you have any queries, again I dropped you already my Instagram and my Telegram handle there, right? So just check it out. That if you have any queries related to this session, you can free feel to contact me, or you can directly contact us, our team, which is the team Meduhub, right? So you can contact the team Meduhub also, and you can contact me here, right? So best of luck for your preparations, and best of luck for your exams also, which is on your 12th January exam, all right? So thank you so much, right? One session for the pedia. Sure, we have the pediatric sessions. Mostly we have the pediatric session tomorrow. Okay, the pediatric session is tomorrow. Okay, we have the pediatric session tomorrow, right? Okay, doctor. For this last time, which is the important time for the revision of the your important things. So we have the tomorrow the session of the pediatrics. Okay. Thank you so much, guys, and best of luck for preparation, and best of luck for your exams from my side and the team MeduHop. Okay. Goodbye. Good luck. Goodbye.